Okay. So I think we have Dr. Sujoy Paul, who's the head of the surgical gastroenterology at the All India Institute, and he'll be talking about indications and timing of surgery, which is a very important part of the surgical treatment for ulcerative colitis. Dr. Sujoy, please.
Yeah, so I've been asked to talk about generally surgery in ulcerative colitis with regard to indications and timing. And I mean, it has become abundantly clear from the previous talk that timing in the emergency situation or when the patient presents to us with a severe acute bout of ulcerative colitis is always a contentious issue because the patient often feels that it's possible that you can salvage the colon and maybe he or she can continue the life without a surgical option. But in our minds, sometimes these things are not easily controlled. So this is basically a brief slide which talks about the prevalence of ulcerative colitis, and it's about 43 per lakh population. And generally speaking, in India, the extraintestinal manifestations are of lower incidence. There is a lower risk of colorectal cancer, and some of the genetic associations are different as compared to the western part of the world. And 10 to 15% of patients in the of ulcerative colitis will ultimately end up with requiring a colectomy within 10 years of diagnosis. Up to 10% of the patients presenting with an acute episode of ulcerative colitis will require hospital admission and will have an emergency operation out of the entire cohort of emergency admissions. And the rates of emergency surgery, as I said, have remained unchanged or somewhat decrease in very highly specialized centers. But as I said earlier, our frequency of colectomies have not appreciably decreased despite the widespread use of biologicals in current practice. So, what are the actual indications then? So, in the acute, severe, or the fulminant ulcerative colitis, the most important reason and the most common or the largest cohort of patients that we get of ulcerative colitis falls in this segment, which is basically the medical rescue is failed, and here surgery has been offered as a way of terminating the acute fulminating episode. Then, of course, there is another segment of patients who have emergency complications like perforation, which can be spontaneous because of toxic megacolon, or maybe iatrogenic because of a colonoscopic induced perforation. There may be massive lower GI bleeding, which is not a very common thing, but it can occur. You have toxic megacolon, as I said, is just another way of uh, talking about the severity of acute colitis. And these are the patients where it is extremely crucial that you take a decision for surgery within 48 hours of instituting the medical therapy. There's no response clinically and radiologically. It's best to go ahead with the operation because you can land up with fecal peritonitis, perforation with significantly high mortality. A large bowel obstruction in ulcerative colitis is a rare occurrence, but when it does, you have to think about malignancy. And of course, in the chronic setting, you have situations where the patient has been having a long-standing colitis and was on surveillance colonoscopy, was detected to have high-grade dysplasia or malignancy, and he's been offered surgery as a salvage. So these are the common indications for ulcerative colitis, the most common being failure of medical therapy in the acute setting. So everybody who is dealing with surgery for inflammatory bowel disease and ulcerative colitis in particular is familiar with the true love and wits criteria, which is age old, and it's actually something which has been ingrained in the our surgical literature as well, where we have been uh, using it commonly to classify the severity based on the frequency of the stools, the blood, the temperature, the general condition, the pulse, hemoglobin, and of course, inflammatory markers. Now, it is important that when you get such a patient, you have to, of course, do a proper clinical and systemic evaluation, along with the abdominal x ray, a gentle sigmoidoscopy with a mucosal biopsy if it's not been done previously. Take the stool samples, get it cultured for Salmonella, Yersinia, Shigella, and Clostridium difficile infection. Also, to look for CMV on the microscopic analysis. avoid use of opioids and anticholinergic agents and antidiarrheal agents and NSAIDs in the acute setting. Use prophylactic subcutaneous low molecular weight heparin. Avoid in those patients who are profusely bleeding, and be vigilant for the development of toxic megacolon or perforation. So these are the initial steps which are common. But the main thing that you're looking at is these are the background data. In acute severe ulcerative colitis, response to steroids remain unchanged for the last 50 years. The failure rate is around 30 to 40%. And the failure following this medical rescue for failed steroid therapy is a further 20%. So the colectomy rate currently varies between around 17 to 29%. The mortality in acute severe ulcerative colitis increases with the age, comorbidity, non-response to medical therapy. And it has been shown eminently in many studies that if there is a medical rescue and that also fails, so there is no second medical rescue, it should not be attempted because the mortality increases prohibitively. So the surgery has to come into the therapeutic armamentarium way, as ma'am said, that the surgeon should be involved right at the beginning when a patient of this type lands up in the emergency. So this is the famous Oxford criteria, which tells us within 3 days whether the patient is going to respond to steroids or not. So classically, by the third day, you should be able to make that judgment with 90% accuracy whether the patient is going to respond to steroids. And if there are signs which are showing that the patient is showing a positive response, then it's well worth continuing the steroid therapy. But if there are signs that there is no change, the frequency of the stools has not changed, the inflammatory markers, the anemia, the toxic symptoms have not changed at all by day 3, then it is time to consider medical rescue, or if in the absence of medical rescue, to consider for a emergency surgery. Now, it is also important to realize that if the medical rescue is being contemplated, that the team which is at hand should be well versed and experienced in dealing with the management of such a sick patient and the use of biological agents in such a situation. And this is the study which was referring to, where rescue of a medical rescue was shown to be prohibitively toxic and way increased morbidity and mortality. So, because of the fact that we have validated predictive rules, which can identify a subset of patients who will eventually fail corticosteroid therapy as early as 3 to 5 days of steroid therapy, that it is important that the decision making is joint right from the beginning, and the issue of second line medical therapy and colectomy should at this time be eminently discussed with the patient. And the patient's failing one medical rescue, colectomy should be regarded as the next logical therapeutic step. So, in our own experience, we have had this initial study that was published from our department, where we looked at 72 patients who had acute severe ulcerative colitis, and we had a mortality of 16.7%. And when we looked at all the patients who died, we found that most of these patients were those who had the treatment of steroid therapy was prolonged for more than 5 days, and they are the ones who ended up having a higher mortality. Of course, we had the groups with toxic megacolon and severe low GI hemorrhage, which also had a high mortality. But refractory severe ulcerative colitis was the biggest group, and the mortality was highest for those with a prolonged treatment. So, looking at using that data, when we implemented it clinically in our practice, day-to-day practice, we again reevaluated our results about 12 years down the line using the same criteria. And here we found that again, those patients who were operated less than 7 days of the initiation of the intensive medical therapy, which actually constituted 58% of this cohort that we presented in 2018, the mortality was as low as 1%. So our conclusion was that we were able to lower the mortality by implementing a strict criteria of operating patients who do not respond to steroid therapy within 7 days of institution of the intensive therapy. And here we are able to show that we could reduce the mortality of the emergency surgery drastically from 15% to about 1%. But this, of course, is a retrospective data analysis and it's an audit of complications, not a prospective data. But still, it's a important fact that we can look at to decide on the timing of surgery. So, in the same vein, the American College of Gastroenterology and the American Society of Colorectal Surgery guidelines also suggest that you should consider a surgical plan within 3 to 5 days of intravenous steroids, specifically in those patients where failure is imminent. And when you have toxic megacolon, you should make an early decision regarding the surgery. If there is no response to medical therapy, the decision to do early surgery should be earlier in those patients with toxic megacolon. So this is actually the algorithmic approach for managing these patients. I don't want to repeat what Dr. Jayanti has already said, but generally speaking, if the medical rescue is also part of this protocol, then by the third or the fourth day, when the change from steroids to, say, for example, infliximab occurs, thereafter, or cyclosporin or tacrolimus occurs, thereafter a waiting period of another 3 to 4 days can be given to see, look for any positive response. If there is a response, then the treatment is continued and the colectomy, the patient is spared a colectomy. But at the end of the 7 days, when the combined medical rescue is also not working, at that point of time, it is the right time to decide whether we should contemplate surgery, and probably the second medical rescue does not have a role. So you're looking at a window period of around 7 to 10 days from the index steroid therapy in such an acutely ill patient. And there has, of course, been a lot of talk about perforation, peritonitis. This is, of course, more commonly seen with Crohn's disease, but in ulcerative colitis also, as I alluded to before, it can be an end result of toxic megacolon which has been neglected, and it could occur because of iatrogenic causes as well. And perforation peritonitis in this setting of toxic colitis carries the highest mortality in the amongst all the complications which can occur in ulcerative colitis. Abscess per se, intra-abdominal abscess per se is not a common finding of ulcerative colitis. It's more to do with Crohn's disease and perforation. By the way, Crohn's and ulcerative colitis in the toxic colitis setting have very little to differentiate clinically. They will present similarly. Obstruction is again uncommon in ulcerative colitis, but when it does occur, we have to think of malignancy. And in that situation, often the emergency situation can be tided over if there is a skillful endoscopic stenting facility available, which can tide over the emergency crisis. And the surgery can be done in a semi-elective setting with a proper bowel preparation so that the things can be sorted out without any untoward effect, and the morbidity and mortality can be minimized. Looking at the bleeding, the bowel obstruction, this is the algorithm. Ulcerative colitis, large bowel obstruction, colonoscopy with biopsy, considering stent as a bridge to surgery. Looking at bleeding again, not a very common occurrence, but when it does occur, those patients who typically require more than 5 to 6 units over a 24-hour period and the bleeding is not stopping despite the institution of therapy are the ones who end up requiring surgery. There are two choices. You can actually either do a total abdominal proctocolectomy with a permanent ileostomy, removing the rectum totally so that bleeding is not an issue. But in many instances, we can get away with a subtotal colectomy, which is usually done. But 12% of these patients will continue to bleed from the rectal pouch. And in them, it has been seen that packing of the retained rectum, administration of mixed saline epinephrine enemas often is able to control the bleeding. And in these patients, then at a later stage, it can be converted to the staged ulcerative colitis procedure that we routinely do for most of these patients subsequently. So what procedure is done? I mean, the detail of all the surgical procedures will be talked about by Professor Das, who will be speaking after me. But the general rule is that in the emergency, A subtotal colectomy with ileostomy is the preferred approach, usually with a long rectal stump, in the sense that the transection is made at the distal sigmoid rectal junction, so that we don't have to do any pelvic dissection at this time. And the if the rectal stump is unhealthy, it can be brought out as a mucus fistula, either through the lower part of the wound or as a separate incision. We prefer to bring out a mucus fistula through a separate incision, because otherwise wound-related morbidity is significant, and you have a terminal ileostomy, which will, of course, later on be converted after the stage procedure. Now, there are instances where we can still have to do total proctocolectomy with ileostomy. You may have a low rectal cancer, in which situation that you may have to do a total proctocolectomy and ileostomy in the emergency setting. Or you have a situation, as I said, where the bleeding is refractory and torrential bleeding is not allowing you to leave the rectal stump intact. So this is the commonest procedure done. We often leave a flatus tube in the rectal pouch so as to decompress the rectum, and we have a terminal ileostomy. The others are variants. Some people close the heart pants pouch just below the skin. Some deliver it as a mucus fistula, and some do a total proctocolectomy, which was the gold standard about 50 years ago, when after the steroid therapy started, the subtotal colectomy is the routine procedure. This is how the colon looks like, typically inflamed red all over with pseudopolyps, and this is a patient with pancolitis. So the rectal stump, as I said, is either left in situ or incorporated into the fascia. Stump-related problems occur in 6 to 12%, and shorter stumps are more prone to leak. So that is why we always leave a longer stump, and we also avoid any pelvic dissection at this time. So post-colectomy, there has been a lot of studies to looking at the morbidity and mortality of colectomy. And in these large systemic analysis, it has been reported that the mortality was substantial, that is 8%. And the 30-day mortality can be as high as 5%. And these are not old data. So morbidity can be as high as 50%. So mortality has, of course, decreased over in the 2000s, and the morbidity has remained still high over the last decade, largely because of repeated the wound-related morbidity and, of course, episodes of adhesive intestinal obstruction. Mortality, of course, after laparoscopic surgery has been reported to be quite low, and the complication rates have also somewhat diminished. And also the occurrence of adhesive intestinal obstruction has decreased after the use of laparoscopic surgery, but for both the subtotal colectomy, the first stage, and the later stages of reconstructive surgery. But these are the timing issues where emergency was involved. There is important timing issues and concern when you're dealing with the patient in an elective setting as well. But before that, I would like to emphasize that the second stage of the procedure that we normally do, that is creation of the pouch and doing a diverting loop ileostomy, is usually done about 6 months after the primary subtotal colectomy. And the third stage is usually done about 8 to 12 weeks after the pouch has been created, and after we are sure that the pouch has a good capacity, has not leaked, and there's no stenosis. There is a special point for women in reproductive age group. It is important to realize that when you do a pouch procedure in these patients, there's a high loss of fecundity in many of these patients, largely because of the pelvic adhesions which are created. So it is always advisable in this age group that you can defer the definitive reconstructive pouch surgery till the time that the family is completed by the patient. And this fact has to be also explained and counseled to these patients before they opt for a pouch procedure. In the setting of colorectal cancer, which was picked up in a colectomy specimen, it's important that you complete all the oncological therapy like adjuvant therapy, the need for radiotherapy before a pouch construction is done, because you cannot do radiotherapy because the pouch doesn't tolerate radiotherapy after a pouch has been created. So these things have to be kept in mind when you have a patient who has developed ulcerative malignancy in the setting of ulcerative colitis. I would end up by saying that the commonest indication for emergency surgery in ulcerative colitis, I mean, it actually remains the commonest indication in our setting as well. whereas a failed medical therapy for acute severe ulcerative colitis. Timing of surgery is the key, preferably within 7 days of initiating a medical therapy and the rescue therapy. Mortality can be reduced, as we have shown in our experience. And subtotal colectomy with endoileostomy remains the optimal surgical procedure for tackling most emergencies in ulcerative colitis. And a coordinated protocol based approach with set timeframes for intervention, close collaboration with your gastro colleagues is very important to achieve good results. And I would always like to quote this: a coordinated protocol based approach, set timeframes with a collaboration between a surgically aware gastroenterologist and a medically informed gastrosurgeon is vital. Uh, I've end my formal presentation. Thank you for the patient listening and thank you for the opportunity, Professor Kapoor.
Deepak.
Thank you, Sujoy. I think your last sentence was really great. Surgically aware medical gastroenterology and medically aware surgeon. I think that's the crux of the decision in acute ulcerative colitis, especially. And I think you're fortunate enough that you've been able to do surgery at 3 to 5 days with the steroid refractory acute phase patients. But otherwise, majority of the places these patients are lingered on with the biologicals and other things before they are referred for surgical interventions. One thing I just wanted to, once these acute phases subside with medical treatment or improve with medical treatment, what percentage of these would ultimately land up with an elective surgical procedure?
Sir, I don't have any data to quote from our experience because
Yeah.
we have very few of those patients. But I would say
Okay.
around 10% will land up with you in the long term.
Yeah. Because these patients, once they are better, they are more likely to have recurrent
Yes.
episodes and
Yeah.
land up with a
Absolutely. In
surgical
fact, the
procedure.
data which says that
30%.
although
Yeah.
you can defer a colectomy in the
Yeah.
uh,
Acute.
acute setting in a large majority of these patients, say around 70% of the patients, but the remnant will, in the next 5 years, at least 25 to 30%, as you said, will land up again with colectomy.
Yeah. Yeah. Another thing I just wanted to ask you regarding dysplasia, I think for the benefit of students, if there is dysplasia on colonoscopy in prolonged ulcerative colitis, how do you go for a surgical intervention? In which patients would you consider surgical intervention if there is a dysplasia?
So when we have patients with dysplasia, we are very particular about targeting the biopsies specifically in the rectum.
Okay.
Like we tell our endoscopists to take multiple biopsies right from the anal verge upwards, the anorectal ring upwards towards so that we can characterize the degree of dysplasia as much as we can. And if there is a dysplasia associated lesion, that also is looked at. And in most patients in our practice, we have tried to avoid offering a pouch procedure for patients presenting with a rectal malignancy. Those who have dysplasia-related colectomies, we'll be staging the procedure in any case, and we'd like to submit it to a proper pathological examination. And if the rectum is clear of any high-grade dysplasia or malignancy, we'll probably submit it to a pouch procedure. But the other caveat is that there are patients, there are groups who also propagate surgery for patients with rectal cancer detected on the setting of ulcerative colitis to undergo pouch procedure. But we haven't done that. And in that setting, they continue to use the transanal mucosectomy as part of the procedure before doing the pouch anal continuity.
Yeah. Yeah. I think that's a debatable topic. If there's a rectal
It
cancer,
remains.
should you go in for a pouch? Majority
Yeah.
would avoid going in for a pouch in such a situation. And I think regarding dysplasias, I would consider if it is a high grade dysplasia, then obviously you treat it almost more like a malignant disease and have a low threshold for a surgical procedure
Surgery.
than a low grade or a DLM type of lesion. Another thing, just to complete the thing, any laparoscopic or other approaches for
Yeah. uh,
for ulcerative colitis in
uh,
acute.
you yourself have been using robots
Yeah, yeah, yeah,
for a pouch
yeah,
procedure. So,
yeah, yeah.
uh, along with robot, both laparoscopic pouch procedure, laparoscopic subtotal colectomy, and
Right.
all these things can be done laparoscopically, and the necessary skill set is easily achievable for doing a subtotal colectomy. But for doing a pouch, there is a steep learning curve of around at
That's
least
right.
100 procedures, and that is why it's not taken up in popularity. But of course, subtotal colectomy can be done eminently, and the good thing about doing minimally invasive techniques is that the chances of having wound related morbidity, the chances of having secondary complications like adhesive intestinal obstruction are minimized, are decreased.
That's right.
So that helps in the long term.
Yeah.
So in your series, how many had left-sided colitis, or were they
Yeah,
all
I was coming to that,
chronic
ma'am,
colitis?
because
Yeah.
when you mentioned that, this is the same dilemma that used to occur to us, that a patient only has left-sided proctocolitis, and we are ending up doing a subtotal colectomy, pouch, and all those things. But of late, in fact, about 15 to 20% of the patients who present to us have severe left-sided proctocolitis, not proctitis, just proctocolitis left-sided. And in all of and some of and many of them are refractory to steroid therapy and other therapies. So we have actually subjected them to pouch procedures, but we have not separately analyzed both of them in our practice. But yes, we have had to do the the conventional procedure is followed even if they are left-sided.
Deepak,
Sir, yes, sir.
just a word of kind of caution to my young colleagues from my own personal experience. I was once doing a laparoscopic colectomy, total colectomy for an emergency indication in a patient with acute severe ulcerative colitis. And I tried to, as you should, stay very close to the wall of the colon, trying to do what is described as a core colectomy, that you core the colon out from the retroperitoneum and from the mesentery. But one has to be careful, because what I did in that case, I was using a harmonic, because when you are going close to the bowel wall, you are getting only the terminal branches of the arteries or the vessels, and you don't have to clip them, and you can take them with an energy source. But in that process, I probably caused a hole somewhere in the colonic wall. And then when we were extracting the specimen, we were not careful. We didn't notice that. And the entire liquid content of the colon spilled into the peritoneal cavity. And this patient, obviously, because this was an emergency surgery, she was on steroids, she was nutritionally poor, and because of this peritoneal contamination, inadvertent or iatrogenic, we lost her. So if you are doing a laparoscopic or a robotic colectomy, you don't have to do it like a malignancy that you have to go to the origin of the vessels, but stay a few millimeter away from the colonic wall, especially if you are using, which you would, energy source. So from my own personal experience, and now retrospectively, I regret that I should not have tried to stay that close to the colonic wall. So just a word of caution.
Another thing, sir, I would just add is, like if you do a diagnostic laparoscopy before starting the procedure, if you're able to hold the colon, then go ahead with the total colectomy laparoscopically. If you have difficulty in holding the colon, because many times it's very friable, straight away convert to an open procedure and do it, because you should have a very low threshold for conversion in these patients with acute severe ulcerative colitis, especially.
Actually, I don't know whether now it is mentioned or not. Earlier, it used to be mentioned in some textbooks that, and also I don't know how many of my young friends have seen a blotting paper. Earlier, when we used to use pen with an ink, after writing, especially after signing a document, we used to dry it up with a blotting paper. Now, blotting paper was a thick, porous paper, but if you dip it in water, it becomes very friable. You can't even hold it. So that is what the colon of acute severe ulcerative colitis was described. It was like a water-soaked blotting paper. You, as Dr. Deepak said, you try to hold it, it just gives way. Sujay,
I
you
think,
want to say something?
sure.
Just a small update on the study that Dr. Jayanti was referring to. I actually cross-checked with one of my colleagues, It's actually a randomized trial of steroid versus steroid and tofacitinib in the acute setting. It's not only tofacitinib. So, and this trial is still in the acquisition phase, not yet completed the number of patients targeted.
The Bombay study was a multi-center study, so they've come ahead with that data.
Maybe.
But it was a retrospective analysis, so they came out with some.
So this is
as a non-biological. They're all named patients, named acute severe ulcerative colitis. Name. The Bombay study.
I think we can move to the next talk now. Dr. Das.
Thank you. Thank you, sir.
Yeah, thank you, Sujoy. Thank you.